I'm going to be talking about the differential diagnosis of lower extremity ulcers. The incidence of lower extremity ulcers in the US ranges between 1 to 2%. They're divided into foot ulcers and leg ulcers. 25 to 50% of leg ulcers and 30% of foot ulcers are not fully healed at 6 months. 70% of leg ulcers are venous. As we know, 20% are arterial or mixed venous arterial, so 10% is something else. 85% of foot ulcers are caused by some form of neuropathy complicated by arterial disease. Everybody in this room has seen this picture a million times, right? The venous ulcer, typical medial malleolus, torn skin appearance, hyperpigmentation. The arterial, typically punched out lesion, hairless, shiny skin, lateral malleolus, and the diabetic is on a pressure point, looks like a callus with a hole in it. Based on that, raise your hand. Who thinks the venous ulcer is A? Who thinks the venous ulcer is B? Who thinks the venous ulcer is C? A is the venous ulcer, B is arterial, and C is an ulcer from allergic vasculitis. They're all on the medial side, lower leg, right where you expect to see a venous ulcer. So not everything is as it appears. So ulcers in the lower extremity can be divided into vascular, neuropathic, metabolic, hematologic, trauma, tumors, infection, pyoderma, and special. So again, that's a 3-hour talk. So in the vascular realm, there's veins. I'm not going to get into that. We all know venous ulcers very well. What I'm going to get into are the other types of ulcers. Arteries can be anything from PAD to hypertension, AV fistulas, thromboangiitis obliterans, which is Buerger's, lymphedema ulcers, vasculitis, such as rheumatoid arthritis with Felty Syndrome, leukoclastic vasculitis, Sjögren's, scleroderma, and microangiopathy from diabetes and livedoid vasculopathy. So I've highlighted there's too many to go through, so I've picked 1 or 2 out of each of these categories to show you one that you might see more often and one that you shouldn't see very often. So in the vascular, here is Buerger's disease, also known as thromboangiitis obliterans, rare disorder, affects mostly young middle-aged cigarette smokers, men, characterized by narrow blockage or occlusion of the veins and the arteries of the extremities, mostly the lower extremities. The first symptoms are usually pain, rest pain, claudication. It can also be associated with Raynaud's phenomenon, and severe cases lead to tissue death and limb loss. In Felty Syndrome, that is defined as rheumatoid arthritis in combination with splenomegaly or leukopenia. The syndrome characteristically occurs in patients with long-standing seropositive RA, nodular and deforming RA. In Caucasian patients, the major histocompatibility locus in Felty's is the disequilibrium with HLA-DRB1. Some patients have no active synovitis, meaning they have no signs of the arthritis when you are diagnosing them with Felty's, so they can appear with the leg ulcer initially. Many of them have indolent lower extremity ulcers with hyperpigmentation and antinuclear antibodies. Neuropathic disease, divided into the peripheral nervous system and the central nervous system. Peripheral nervous system being common in diabetes, alcohol, medication-induced, and central nervous system, tabes dorsalis, spina bifida, polio, and multiple sclerosis. Most commonly, when we think of a neuropathic ulcer, we think of a pressure point ulcer due to lack of sensation. However, wound healing also requires a functional immune system and a functional sympathetic nervous system. The sympathetic nervous system is what is responsible for transmitting the response to the immune system for infection-fighting cells to make their way to the wound. So studies have shown that in sympathetic nervous system injuries, such as in diabetes, MS, spinal cord injuries, the immune system is not able to detect the actual injury, so they're not able to get the immune-fighting cells to the ulcer. Patients with ALS, amyotrophic lateral sclerosis, which mainly affects the motor neurons and not the sensory neurons, do not have that problem. Metabolic, we have diabetes, gout, prolidase deficiency, Gaucher's, amyloidosis, calciphylaxis, porphyria, and hyperhomocystinemia. So gout, this is something that you may see quite often. I do see this in my office a lot. Tophaceous gout wounds are uncommon, but it's a worldwide problem and challenging to treat. Small ulcers, usually on the foot, typically in the area of the great toe. Topical treatments for that, collagen, silver-containing dressings. Large ulcers may require flaps, and the key to treatment is medical management of the gout. Amyloidosis, this is a group of disorders, and there are 3 separate types. Lichen amyloidosis is the most common, and it presents as multiple pruritic hyperkeratotic papules, which coalesce usually in the area of the shin or extensor areas. The macular form presents as hyperpigmented macules, usually on the upper back. And the third, but the rarest form, is nodular amyloidosis, which presents as a single nodule, multiple waxy nodules on the trunk and extremities. Hematologic. With erythrocytes, we have sickle cell anemia, thalassemia, polythysemia vera, leukocytes, leukemia, thrombocythemia, and then we have cryoglobulinemia and the coagulation or clotting factors. I chose sickle cell disease to show to you because leg ulcers are actually very common in sickle cell disease. They tend to occur in the same location as venous ulcers, area in the lower extremity with thin skin, particularly at the medial malleolus. It's the incidence is highest among male patients from low socioeconomic backgrounds, and the incidence can vary among the different phenotypes of sickle cell disease. Exogenous forms of lower extremity ulcers include heat, cold, pressure, radiation, foreign bodies, noxious chemicals, and allergens. Radiation injury is one I chose to present here. This can happen anywhere from 4 weeks to 3 months after radiation exposure. The area of radiation exposure is erythematous, hyper or hypopigmented, and desquamation and hair loss. During the acute period, there's a full thickness skin damage and tissue necrosis. Late or chronic radiation can show up in skin with thickened skin, fibrotic changes, hyperpigmentation, telangiectasia, and atrophy. Neoplasia, primary cutaneous malignancies such as basal cell, squamous cell, angiosarcoma, cutaneous lymphoma, or metastasis, papillomatosis, cutis carcinoides, or keratocanthoma. I chose Marjolin's ulcer because that's an ulcer that occurs in chronic injuries or chronic wounds, such as venous ulcers. It is a malignant change in the edge or base of the ulcer. Squamous cell cancer is the change. There are 2 forms. The poor prognosis is the flat or indurated type that you see here, and the better prognosis is the warty or exophytic form. Under infection, we have bacteria, including furuncles, Mycobacteroides, syphilis, erysipelas, diphtheria. We have viruses such as herpes, CMV, fungi, histoplasmosis, and coccidiomycosis, and protozoa such as leishmaniasis. I chose syphilis. So a gumma is what is called tertiary syphilis. A gumma is a mass of inflammatory tissue after being infected with the Treponema pallidum, the syphilis infection, and it appears usually a year after infection. This is a gumma. It's on the medial lower leg, and it can also present with joint deformities, cardiovascular problems, and mental changes. We also have medication ulcers, including hydroxyurea, methotrexate, halogens, Coumadin, vaccinations, ergotamine. This one is warfarin-induced skin necrosis, so that is pretty rare, 0.01% to 0.1% incidence on patients with warfarin. Diagnosis is usually made by this ulcer forming in proximity to administration of Coumadin. They're macroscopically characteristic with petechia, ecchymosis, and hemorrhagic bulla. And the histologic features are microthrombi and thrombi within the blood vessels of the dermis and the subcutaneous tissue. Genetic defects, Klinefelter syndrome, TAP1 mutation, leukocyte adhesion deficiency, and factor V mutation. I chose Klinefelter's to talk about. It's the most common congenital abnormality occurring in 1 in 500 to 1 in 1,000. Phenotypically male patients with an extra X chromosome. Leg ulceration is a characteristic complication of Klinefelter's, and the etiology is believed to be a combination multifactorial with chronic venous insufficiency, obesity, arterial dysplasia in legs, fibrinolysis, elevated plasminogen activator inhibitor 1. Those have all been reported in inciting factors for ulcers in Klinefelter's. And finally, the skin disorders such as pyoderma, necrobiosis lipoidica, sarcoidosis, perforating dermatosis, Langerhans, and bullous skin disease. And I'm wrapping up with one that you guys all helped me with here. It was a great help, and I appreciate. I had a patient that came into my office with well, I didn't know what he had, but that picture on the left, it was very awful, and I sent that photo out to all of you, and I got a mass email response. Everybody told me that this was pyoderma. Pyoderma gangrenosum starts usually with a small red bump in the skin, which may resemble a spider bite. It usually develops a black necrotic center and then just expands from that. The exact cause is unknown. It's not infectious. It's not contagious. It's often associated with autoimmune disease, but does not need to be. But the autoimmune disease usually is ulcerative colitis or Crohn's and some form of arthritis. It may have a genetic component. Diagnosis is pretty difficult. It's usually a diagnosis of exclusion. Biopsies can be taken, but those you can get false negatives with. The treatment is usually with topical and/or systemic steroids. For my patient, you guys recommended I send him to the ER. I did. They put him on IV steroids. This was him a few months later, so he was healing quite well with that, but he was on and off compliant with his oral steroids when he left the hospital.